Okay. Okay. So good morning. Happy New Year and welcome to the first session of 2023 already. It's amazing how fast, and it's already January the 12th. So we have the pleasure of having Nav. So Navdeep Dehar is one of our PGY5, soon to be our fellow at the end of her training in medical oncology. And so she recently attended the San Antonio Breast Conference. So we'll have the opportunity to get some highlights from that very important breast cancer meeting. So just a quick bio about Nav. So as I mentioned, she is a senior resident in medical oncology. She trained, so her med school was in India. And then after completing medical school there, she underwent to get a postgraduate degree in pharmacology. And then she moved in 2012 to Calgary, where she did in internal medicine. And since last year, she's our medical oncology resident. So it's a pleasure having her here. So now the podium is yours. And thank you for presenting. Oh, you don't need this one. Perfect.
Thank you very much, Dr. Herbadillo. Hello, everyone, and thank you for joining in this morning. And it is my extreme pleasure to share with you all the data which was presented at the San Antonio Breast Cancer Conference. And here are my objectives. Okay, so we'll be reviewing the recent advances in breast cancer presented at the San Antonio conference. We'll study the impact and applications of the practice-changing clinical trial data. And following this, we'll discuss how we can implement these into our clinical practice. So before I actually jump on to talking about the clinical data, I would just like to tell you my experience at San Antonio. I was there for
Going to jump on here.
Yeah.
It's not sharing to our participants online. So.
Okay, just giving a thumbs up. All right. All right. I don't know. Do you want me to go over the objectives again? But I guess everybody can see that on the flyer. So I'll keep moving on. So yeah, it was my first San Antonio conference, and I had a great time there. San Antonio is a beautiful city with a very unique history. At the conference, I was also able to present my research project, which I did with Dr. Maris and Dr. Doris Jabs, and I would like to take this opportunity to tell you a little bit about my project. So we did this study where we wanted to look at the outcomes of diagnostic mammograms and ultrasound in young females from 30 to 50 years. And as we all know that in Canada, screening mammogram is recommended after the age of 50 years in women at average risk of breast cancer. And younger women tend to have more aggressive disease, with higher rates of delayed diagnosis as well as metastatic disease at the time of presentation. And we really don't know how these investigations are well enough to detect the disease upfront. So, and false negative imaging is unknown in this cohort of patients. So we did this retrospective chart review. It was done obviously in the average risk breast cancer patients. And these were the females who actually came with the symptomatic breast concerns. Patient underwent diagnostic mammogram and the ultrasounds between 2018 to 2019, and we collected multiple data points, which included clinical breast concerns, what kinds of clinical presentations they had, and then type of initial breast imaging, followed by their, follow-up investigations, their diagnosis, stage, and treatment. The primary outcome was to detect the delayed diagnosis of the breast cancer as defined by more than 6 months from the first diagnostic imaging. And then we had secondary objectives of, looking up their workup and how many patients ended up having the diagnosis of cancer. So we screened 400 charts, 171 were eligible. If you see here, majority patients had both ultrasound and mammogram, and followed by ultrasound being the most common investigations. A lot of patients, around over 50%, had benign findings, but all of them did end up getting the required follow-up investigations. And then for the BIRADS 4 and 5, all of them did end up getting biopsies, and only 10 patients out of the whole cohort had the breast cancer diagnosis. So with respect to those 10 patients, the mean age was 43, and they were all early stage disease, and they got their required treatments as per their staging. And most common breast clinical concern was breast mass or pain in the breast. And at the end, we found out that there was no delayed diagnosis, and the mean time from first imaging to the biopsy was 2 weeks. So in conclusion, diagnostic mammograms and ultrasounds are appropriate diagnostic investigations for clinical breast concerns in this age group of patients. So now I will move on to the clinical data presented. There were a lot of studies. I'm not going to talk about all of them. So I've picked my good ones, and I will talk about them. So starting off with the early stage breast cancer, the first study I want to talk about is the updated results of Monarch E. We all know about this study, and the initial data has already been presented, but at San Antonio, they presented the 4-year efficacy outcomes because the follow-up is still ongoing. And then there were interim overall survival analysis update as well. So we know that adjuvant abemaciclib, along with endocrine therapy, has shown the invasive disease-free survival and distant relapse-free survival benefit in high-risk hormone receptor positive, node positive early breast cancer patients. And at that time, when they did the initial outcome analysis in 2020, the median follow-up was 15 months. At this time, it's 42 months. Here is the diagram showing the Kaplan-Meier curves for the benefit in the primary outcome of invasive disease-free survival. And we can see that the combination of abemaciclib with endocrine therapy is superior to the endocrine therapy alone, with a statistically significant hazard ratio of 0.66. And there was a 33% reduction in the risk of developing IDFS event. And from the first analysis at 2 years, the benefit was 2.8, and it rose to 6.4 at this analysis time point. So the similar kind of results we can see in DRFS endpoint as well. The OS benefit is still kind of immature, so we'll see. The OS data is immature, and we'll see how it ends up. So this was an important point that this analysis did bring up, was that the Ki-67 is now prognostic based on this observation in the study. However, the drug is still approved on the basis of the Ki-67, which in fact is not predictive of the benefit. If you see here, the solid lines here, the blue line is for the group with the endocrine therapy alone, and the solid red line is the abemaciclib plus endocrine therapy, and the single agent or the patients with endocrine therapy alone, they tend to do worse than the abemaciclib group. And in the table here, you can see that the cohort 1 was divided into Ki-67 high and low groups, and the hazard ratio is unchanged between the two groups. So clearly showing that the benefit of this combination is regardless of the Ki-67. The investigators concluded that the addition of abemaciclib to the endocrine therapy deepens the magnitude of the benefit, and this has been demonstrated over 4 years of follow-up now. And Ki-67, as we say, is now is prognostic, and then we'll see what the OS data shows. So how is this significant for our Canadian practice? I've seen only a few of the staff here at our center are using this drug in the adjuvant setting, but in the end, maybe we can just go over and discuss what everybody's practice is like, but this is my take on this, this study and the data. So the use of CDK inhibitor in the adjuvant setting is controversial. And the question which I'm asking is that, do we really need a drug with the PFS only benefit in the adjuvant setting when we don't have an OS data yet? We have experience from the PALLAS and the PANELOPE studies, in which the palbociclib did not do good. And the Ki-67 at this time is not predictive. However, FDA has approved this based on this indication. And IDFS is not a validated surrogate marker in endocrine positive group. It is for the HER2 positive group. So that's also something to keep in mind when we are using these drugs in the clinical setting based on a surrogate marker, which is not validated. And then the therapeutic burden and side effect for 2 years, which you are giving to these patients, is another thing that should be taken into consideration. Oh, I'm sorry. And then there is this paper by our own Dr. Gavali about the use of CDK in adjuvant setting. It was published in August of 2022. There's more about this issue there. However, in the end, there's big question now that if we use these agents in the adjuvant setting, what are we going to do or use, or how do we make decisions when they progress? And recently, ASCO and NCCN, they did update the guidelines saying that Ki-67 is just going to be an additional marker to look for the use. It's not an absolute thing that the patient should have that number of over 20% for Ki-67 for use. Interesting enough, in Canada, though, Canada has approved this drug with the indication, if you see here, it is for clinical pathological features along with the Ki-67. So we do see some discrepancy there, and it'll be interesting how we can discuss this. Okay, moving on to the advanced breast cancer setting. So we all know that the first line treatment for metastatic breast cancer, hormone receptor positive setting, are combination of endocrine and CDK. I'm not going to discuss about this table. We all know, we've seen this multiple times, but the one thing we all can acknowledge that it's only the ribociclib which has shown the overall survival benefit. But in patients who progress on the endocrine therapy, there is really, two ways where this can go. So we assume that, and we know, and in other words, that patients tend to develop resistance to the endocrine therapy. And there can be two pathways where there is development of ESR1 mutation, where it is called as the ER-dependent pathway. On the other side, we have this ER-independent pathway where there is PIK3, AKT, and mTOR. I'll call it as a PAM pathway. So the first drug that was approved in this setting was alpelisib in combination with fulvestrant in the SOLAR-1 trial. And we all know that this got an accelerated approval by the FDA when it showed a PFS benefit. And this is now approved in Canada as well for the same indication for patients who have PIK3CA mutation in hormone receptor positive, HER2 negative advanced breast cancer. However, it's still under review by CADET for funding. Moving on, the downstream target in the PAM pathway is AKT, and the first drug that came into being was from the FACTION trial combination of capivasertib and fulvestrant, and this showed also showed PFS benefit. And this was later taken to the phase 3 trial, which is CAPItello 291. And a lot of people were waiting to see the results of this trial, which were presented at San Antonio in December. So capivasertib and fulvestrant was compared to the AI resistant hormone receptor positive, HER2 negative advanced breast cancer patients. AKT basically is has 3 isoforms, and capivasertib tends to target all 3 of them. And in this study, the patients who had recurrence while on or less than 12 months from the adjuvant AI or progression while on prior AI for advanced breast cancer were included. Less than equal to 2 endocrine therapies were allowed. At least 1 or less than 1 chemotherapy was allowed. Prior CDK use was allowed. That was different from the earlier study, like the phase 2 study. And that's important because it's more closer to the real life setting. And then there were no prior SERD, mTOR, or PIK3 or AKT, other targeted agents allowed. And then important to note that with the observation of hyperglycemia with the alpelisib, this study did not allow the patients who had uncontrolled diabetes or were on insulin. So there were 2 groups, 708 patients, 1-to-1 randomization, capivasertib given on its standard dosing. PFS was the primary endpoint. This trial actually was hybrid. They wanted to see, so they had 2 primary endpoints. So the first one was in overall population, and then the AKT altered pathway tumors were also looked at, and then overall survival as a secondary endpoint. So looking here, there is definitely like spreading of the separation of the Kaplan-Meier curves. There is a statistically significant benefit of capivasertib with fulvestrant and hazard ratio of 0.60. And median PFS is 7.2, almost double from the single, so placebo plus the fulvestrant group. And in the AKT pathway, kind of similar results were there. There was not like much advantage seen, but overall survival is still immature. With respect to the adverse effects of this combination, diarrhea is most common, followed by nausea. And I've just highlighted here, this was the study where the incidence of hyperglycemia with the use of capivasertib was much less than the previous alpelisib combination. And this treatment was much tolerated. So capivasertib provides a statistically significant, clinically meaningful improvement in the PFS in both the overall and the AKT altered pathway. And the overall survival will still wait for. Regarding the impact on the clinical practice, so the big question is, if once it is approved, which it is not at this moment, are we or will we be comfortable to switch it with the alpelisib? And the reasons which I give is that this is a more specific target. Alpelisib tends to, inhibit also the wild isoform of the PIK3 receptor, so ends up giving, hyperglycemia. And then benefit is seen in all comers. This trial is more closer to real life population, as I mentioned, as the CDK use was allowed. It has better side effect profile. And however, I just wanted to bring this to everybody's attention, and maybe this could also help us to kind of transition to capivasertib, is the issues that were brought by the SOLAR-1 trial. The final analysis in 2020 actually did not reach to the statistical significance. The 8-month survival benefit actually did not meet this significance. It was published in the ASCO post. And then the interesting thing, though, is this is just a snapshot from the paper published on flawed clinical trials by Dr. Ian Tannock, who has mentioned this trial, that there was informative censoring in 39% of the patients in the experimental arm. So that way, there is an impact on overestimation of the results. So again, something to keep in mind, and taking the results or applying this with a grain of salt. Having said all of the issues and everything, that's one part, but ASCO guidelines, they have still mentioned alpelisib as, the agent that should be used for these PIK3 mutated advanced breast cancer patients. Something to just think about. So moving on, I'll talk about camizestrant. It is a new next generation oral SERD versus fulvestrant in the post menopausal, females with the advanced ER positive, HER2 negative breast cancer. The results for the phase 2 Serena trial. Another one which everybody was looking forward to, those were presented here. And this study, again, patients had recurrence and progression on at least one endocrine therapy. Then there was no prior fulvestrant use allowed or any other oral SERD. No more than one endocrine therapy or chemotherapy was allowed. So there was randomization to 4 groups, and I'm sorry, I should have mentioned that this was a multi-dose testing for this agent. So if you see there are 3 doses. Those were initially included at the time of beginning of the trial, which was camizestrant, 300, they're followed by 150, and then there's 75 milligram dose. And comparison was with single agent fulvestrant, because that's now we are moving into the oral SERD category. And primary endpoint was PFS only. And they also looked at the effect in the ESR mutated population. Now, I would highlight here that the camizestrant 300 milligram dose, when they started recruiting the patients, the first 20 patients did not show the dose response effect. So this dose was dropped by the investigators, and rest of the patients in 240 cohort were, apart from those 20, were 75 and 150 milligrams. And then here are the results. So the first initial results do show that in overall population, camizestrant produces a statistically significant and clinically meaningful improvement in both the doses. If you see here, the hazard ratio, which is adjusted here for the prior CDK use and liver metastasis, is 0.58 in 75 milligram group and 0.67 in the 150 milligram group. And then there is a median PFS of 7.2 at 75 milligrams, 7.7 at 150, and then it's almost a double, median PFS, and fulvestrant was 3.7. The next sorry, it's just got stuck. The thing is, I cannot see my cursor. Did I go back? Can you check? No, I can't see my cursor here. Oh, damn.
That's okay. There we go. Bring it back over.
Is that the next one? Where's it? Okay.
Your cursor's right here.
Okay. Okay, sorry. So the next, there was this subgroup analysis done in endocrine resistant driven disease, and there was some benefit seen with especially with the 150 milligram dose. If you can see in the middle there, their median PFS was 12 in comparison to 3.2 with a statistically significant hazard ratio. And that benefit was not seen, as you can see, the median PFS remains same, and the hazard ratio has crossed 150 milligram dose. Next is the ESR1 mutation group. This was another subgroup analysis that was done. So here the ESR mutation group showed benefit in the 150 milligram dose. There's some benefit in the 75 milligram dose in comparison to fulvestrant, which was only 2.2 months. And then with statistically significant hazard ratio at 0.33 and 0.55. So this drug is known to cause photopsia, sinus bradycardia. However, there were not many patients in there were no patients in the 75 milligram, but not many patients in the 150 milligrams. And then for the fulvestrant group, we already know that what this drug is used to cause. There were no new signals in that group, but this newer agent was very well tolerated at both the doses. So in conclusion, the investigators concluded basically that this trial met its primary endpoint at both the doses, improving the PFS, and camizestrant actually delivers meaningful benefit, as I said, like at both doses, but also specifically with the ESR mutant as well as in the ER-driven disease. So impact on the Canadian practice. So this is a promising second-line new agent. However, patient selection would be challenging in this, like looking at the results. So endocrine sensitive disease, there is ESR1 and as well as ESR1 mutant patients. Phase 3 trial is now ongoing at 75 milligram dose only. That's what the investigators decided. Again, I've already said that the patient selection would be a challenge, also given now that we have data from the PIK3CA. So moving on to the Emerald phase 3 trial, we all know about the results for the Emerald trial. This is just an update on the basis of duration of the prior CDK use. And this was basically, I'll tell you that celacestrant is an oral SERD, and it has demonstrated statistically significant improvement in PFS. And here, the results, the study design, I'll just quickly tell everyone for the review. They had patients who had progressed and relapsed on 1 or 2 lines of therapy. There were 2 groups, elacestrant 400 milligrams, and they included AI, exemestane, and fulvestrant in the other group. And there were, again, like 2 primary endpoints in this study with the PFS in all patients and with the ESR mutant. So this table here shows that if you pay attention, there are 3 timelines, 6 months, 12 months, and 18 months. The median PFS is, yeah, it is different, but it's not like hugely different. It does go up from 2.7 to 5.45. And then the hazard ratio is more important to pay attention that it's not much changed. There is a bit of a better, numbers to see here only at the, in the ESR mutant group. At the 12 months mark, there was some difference seen. So the standard endocrine therapy had a median PFS of 1.9 versus 8.6. But if you move forward at 18 months, it's unchanged. And the hazard ratios also, they don't differ much. So the conclusion by the investigators was that duration of CDK does, impact the PFS. It is associated with PFS. The longer the duration of CDK, the longer the PFS on elacestrant as compared to the standard of care. And then this was more pronounced in the ESR1 mutant group. And they also said, just like how I pointed out, that the duration of at least 12 months is actually more beneficial to have a better PFS, which was 8.6 months versus 2.1 months with the fulvestrant. So regarding this agent, elacestrant definitely is another oral SERD with the potential to be used in the second-line setting. The benefit with the duration of CDK, yeah, we saw that at 12-month mark, which is obviously the definition for the secondary endocrine resistance at this time by the ESO-ASMO guidelines. There is some benefit there, but again, it's not something that will stand out or help me to just choose this agent for that purpose. So the challenge again is the targets. So ESR mutation is currently not clinically validated biomarker. So until that comes out and we have access to that, I think that this will still be difficult. So another thing is the challenge is to choose between fulvestrant alpelisib versus a single agent elacestrant. Here you're using single agent versus alpelisib. I've chosen that because it is at this time the only agent for PIK3 which is approved, and we all know about the efficacy and toxicity we talked about. So this was all that the patients could be detected for mutations, and then we could choose the agents in the second line setting. What about the patients who do not have targetable mutations? So what do we have for them? So there is a thought of giving a second course of CDK after they have used it in the first line setting. This was just a real world data study done in 6 US centers, 87 patients, and it shows that abemaciclib does have some benefit only in a fraction of patients. We all know about the PARA. It only showed minimal, 2.7 months benefit. This was switched to fulvestrant and palbo with no switch in the advanced breast cancer. But again, ESR1 mutant patients. And then maintain trial showed that maintaining ribociclib after the first CDK, which in this study, if you pay attention, 87% of the patients had previous palbociclib. This showed a little bit of PFS benefit with hazard ratio of 0.57. On the contrary, we do have data now from PACE trial, which was presented at San Antonio, that the palbociclib after, palbociclib use along with endocrine therapy does not have much benefit. In this particular study, they also added a IO arm, which was the third group here. If you see the fulvestrant with palbociclib, and they wanted to see if addition of IO makes any difference. And then fulvestrant was the other first group, and they also had a combination of fulvestrant and palbociclib in the other group. There were 220 patients, and 1:2:1 randomization was done. And here are the results of the PACE trial. So if you see here, the first two groups of fulvestrant and fulvestrant plus palbo, they are exactly, running close to each other, no separation here. There was some signal in the third group, though, that maybe the addition of IO can give some benefit. Again, it's too early. It was a very small study, so this needs to be, investigated in a larger trial. And similarly, overall survival also data did not fetch much good results. So based on this, as I have said, we now know that palbo after palbo is not beneficial. Maintain gives us a little bit of the data. However, we should keep in mind it was the palbo switch to ribo in majority patients. And then there are several questions. Again, this concept of using CDK after CDK is another area which needs more work. And it is controversial at this moment because we need to think that like a lot of things are unanswered at this moment. CDK use after the progression to continue with same CDK, whether we should change the endocrine arm or the CDK drug itself. What about the use of oral SERDs given the results from the Emerald and Serena? Yeah, we know that the targets are needed for use of these agents, but again, unless and until we get those, our hands are tied. So overall, I would say ideally a biomarker-driven approach will help us in the second line setting rather than this approach, as we have a lot of stuff to think about. So this was a very interesting study that was presented at San Antonio. It's called the Right Choice Trial. This was done by a Taiwan group, and they presented the primary results of phase 2 premenopausal patients, and they used CDK plus endocrine in high visceral disease patients in combination to the physician choice chemotherapy. We are all aware that patients who have the life-threatening visceral crisis, chemotherapy, sometimes combination chemotherapy needs to be given even in the metastatic setting to have the initial control of the disease. And they wanted to see if in that setting we can still use the CDK inhibitors. So this study included aggressive disease patients, which according to the study, they defined as symptomatic visceral metastasis, rapid disease progression, or impending visceral compromise, and marked symptomatic non-visceral disease. And then I want to bring your attention to this particular definition here, because this is different from the ABC, ESO, ESMO, definitions for the visceral crisis, and I'm going to mention it in my slide further. And please pay attention to this thing also, because the definition for the impending visceral crisis because of high burden disease, that by definition, these patients tend to have poor liver function, and all of these patients were excluded in this trial. There were two groups, 222 patients, 1-to-1 randomization. They used ribo plus letrozole or goserelin because this was only the premenopausal group, and they used the ovarian suppression as well. And then the investigator choice of chemotherapy, which again, I would like to know what combinations, if at all, somebody in the audience may have used in this setting, whether you prefer combination versus a sequential. So, and then they did some evaluation on repeat CT scans or imaging. PFS was the primary endpoint. They wanted to see the time to treatment failure, overall response, and then there is this time to treatment response as well. And then we have this initial results. If you see there, around 79% patients had both liver and lung metastasis. There was symptomatic visceral metastasis in 66% patient and visceral crisis in almost over 50% patients. And then the ribociclib group had a good overall response rate, slightly better than the chemotherapy. And then the clinical benefit rate was also better with the CDK group. And the results here show that the first line use of ribo did, change the PFS, and they gave almost 1 year of additional benefit in these patients with a statistically significant hazard ratio of 0.54. And then we have the median time to failure here, which was lower in the endocrine therapy group in comparison to the chemotherapy. And then here is the time to response. I think that is most important because we are using chemotherapy and we need an early response. That's kind of the main goal here. So here it was actually unchanged and both the groups did the same. With respect to safety, we are all aware of this side effects of ribo. Those were the main ones which were primarily seen. And then if you see here, the discontinuation rate was higher in the chemotherapy group than the endocrine group. In conclusion, with the right choice clinical trial, use of CDK and endocrine is possible option in the aggressive clinical disease patients with rapid progression and symptomatic disease, visceral crisis. There is a longer time to treatment failure as well as shorter, time to response. However, what I think about this study is that, yes, it has confirmed the effects of CDK in the metastatic setting in first line, absolutely. There is some benefit seen in the visceral crisis patient, but again, the definition is not optimal. We have to see that this is still a phase 2 trial, small number of patients. This was a study done by the Taiwan group, so they were primarily Asians. And chemotherapy regimens, I don't think it's representative of our Canadian practice. Again, the study selection is only for premenopausal here. The question would be whether we can, extrapolate it into the postmenopausal group. And the definition of the high burden disease versus visceral crisis. This is the ABC definition. If you see here below, liver visceral crisis actually needs it can have a bilirubin of more than 1.5, and all these patients were excluded in this trial, something to pay attention to. The last 2 slides I'm going to talk about is the antibody drug conjugates. We are all aware that 2022 was a blockbuster year where a number of antibody drug conjugates did get approved, starting off with DESTINY-Breast04, TDXD in HER2-low patients, followed by sacituzumab govitecan from TROPiCS-02 trial. We had some data updates in the San Antonio with that as well. And last but not the least, DESTINY-Breast03 results were presented, and these now confirm that I know that we are using TDXD in the second line setting already, but these results were good to see that it kind of affirms our practice in the day-to-day life. So we all know that DB03 was a study, like a randomized phase 3. There was a comparison of TDXD and TDM1 in the second line setting, and the primary endpoint was PFS. Here is the update of the primary endpoint. And I was quite excited to see this because if you see here, there's a very nice separation of the occurs very early on. However, if you see here, the median PFS is now 28.8 months versus 6.8 in the TDM1 group. And it's almost 4 times longer. So with a hazard ratio, which is currently at 0.33. And even with that, we still don't have the overall survival. So which is really good, but it's good to see that even at this stage, the hazard ratio is showing statistically significant results. And we are all aware about this interstitial pneumonitis as a side effect. So in the updated results, the investigators said that with the longer treatment exposure, the ILD pneumonitis did increase from 10.5 to 15.2%. However, there were no additional grade 4 or 5 events, which was good to know. There were only a few grade 1 and grade 2 events, and then no additional grade 3 events as well. So overall, it is seen that as in how we are getting more experience with this drug, I think we are understanding how to manage this side effect and people are getting the benefit. And then regarding this drug, as I said, we are already using it. So these results just affirm our practice that it is a really good drug for second line setting with that good PFS benefit. And then it is now approved and funded here in the second line setting for patients with unresectable metastatic hormone receptor positive, HER2 negative patients. And then TDXD at this time is under investigation for the first line setting with the Destiny Breast 09. I'm sorry, it was a whirlwind of data, but I see that I still managed to finish before 8:45. So thank you so much for your patience. That is all from me. I would happily take if there are any questions or comments.
Any questions for now?
First of all, I just want to say thank you, Nav. That was great. Oh, sorry. Thank you. That was great. It's a lot of studies to review and also show the context. I guess I'm trying to just you mentioned just going back to the first study, the adjuvant abemaciclib. How would you go about selecting the patients and who do you think would be most appropriate based on these the findings? And I know we always struggle in clinic, obviously these are all high risk patients, and we know that they have a high risk of recurrence and mostly the recurrence that can happen 5-10 years later in this population. So who do you think would be the best to approach on this study, or would you just approach everybody that meets the criteria, and would you be comfortable based on this data and the side effects, obviously? So what I'm really trying to say, because I know we were hesitant when the first publication came, and now over time they don't seem to lose the benefit of these after they stop. Like the idea was that the first 2 years is when they stay on treatment, but then what happens after they stop? Now they have 4-year data. Do you think this is enough for us to be comfortable prescribing it?
So I think there were a few things in the study which I obviously have mentioned my thoughts about the use of CDK in the adjuvant setting. But if I were to seriously think about it, I think the study included the patients with the clinical pathological features of more than equal to 4 lymph node involvement. And then if they had lesser lymph node involvement, they had to be grade 3. And then now based on the ASCO and NCCN, you could have a Ki-67 along with 1 to 3 lymph node involvement. Having said that, we also know on the other hand that we have come a long way from, treating the high-risk patients with the hormone receptor positive disease with ovarian suppression. We usually try to add that for these patients in the adjuvant setting, and then also like extended endocrine therapy, which is again the same kind of idea that we want to reduce the risk. I would think that this, for the use of CDK, if I'm convinced with the OS data, so that's for sure something which I would look forward to, even though it's at 4 years, but we know that the recurrence is kind of down the line. So maybe that's the reason it's taking so much time to show the benefit. So coming back to the question, which patients which I will select. So I think it's going to be very, very small group of patients, very specific characteristics. One thing good is that I would be off the hook to wait for Ki-67 if that happens in Canada, because we still need Ki-67 as per the Canadian, or the CADEC approval. So if things change, yes, maybe, but for now, I personally also not seen it very commonly done, but I believe it's going to be very, very small and very specific group of patients.
Any other questions?
Alice?
Alex?
Just in terms of managing side effects, I just noted there was this difference in the hyperglycemia. The number of proportion of patients that ended up with hyperglycemia in Capitello 291 and versus another trial, which also used the same agent. Could you just let us know what you think that was about and how relevant that is for our own practice? Because, like, again, managing toxicity is part of what we do. We don't want to end up with lots of toxicity and having to sort of sort that out.
That's an excellent question, and that kind of is going to be a game changer too, because I think that and Dr. Brooke Wilson is sitting here. She's the expert on the pathways. So this is what I learned from my own reading, that PIK3CA, it has it affects both the sorry, I'll back up. So alpelisib is a PIK3CA inhibitor, and it actually works on the mutant, but as well as also inhibits the wild type version of the gene. So which is actually, its function is to regulate the insulin, action intracellularly. So once it inhibits that wild form, that's where the hyperglycemia comes, and that's something unavoidable, unfortunately. But with capivasertib, it's kind of down the line target, and it's AKT only. So that's the reason why I think there's less of hyperglycemia. Did I pass there?
Oh yeah, I guess thanks, Nav. I think that was really great. I think one of the studies, you look at these presentations and they're all very interesting, but there's so few that we can apply today in practice. So I know when we were talking yesterday, I think highlighting the right choice study is really important, because it is one that we can potentially apply tomorrow. And I think you made really good points about the critiquing of the type of chemotherapy. The other thing I think it's worth pointing out is in that study, if I remember correctly, chemotherapy was given for up to a year. And if you look at the curves, there's actually no separation for this first 6 months. So patients do the same for the first 6 months. And in our practice here, we would often, for these patients, give induction chemotherapy for approximately 6 months. And then if they're doing well, consider changing them to a CDK4/6 then. So I think there's a lot of granular detail that's missing. I think it certainly supports narrowing the population in who you would think about giving aggressive chemotherapy up front, which is the main take-home message. But I agree that there's a lot of uncertainty and interesting things that will hopefully come out in the publication.
Yeah. Thank you.
There is a question online.